Awesome. Welcome back. Welcome back. Apologies for the challenges with technology, but we want to take just a few minutes now to hear briefly from each group for the sake of time, because I know you guys would like to get out of here by 5 o'clock since it's Friday and off. So what we'll do is let's start with group one. And group one, I would like you just to share maybe two in response to that first question of who should be invited to partner on this grant application and why. So just maybe share a couple partners that you selected and why. Is someone available from group one?
It should be Ying Guo. And so if he can unmute himself.
Can you hear me?
Yep,
Yes.
we can hear you.
Yeah, I'm sorry, I put a note to the small group before. Yeah, for that we should be involved to partner on this grant application. I think the group member mentioned that parents should be involved, and also the way that how to basically get access to the parents. Then probably potentially PTA is a reach out, but parents could be busy in the group. And also the WAKE program, it can also be a good resource. And also consider about the socioeconomic titles or the parents, and to avoid any discrimination in such kind of places. And maybe find it, maybe the partners can also be involved from the local schools, like Head Starts programs, something like that.
Great, thank you. And I'd like to have someone from group two answer that same question. Just give us a couple partners who you think should be invited on this grant application and why.
I think that's great. Madeline.
Go
Oh, Anne, go ahead.
No, Madeline, that's fine.
Hi. So basically what we had said were like members of the community should be involved, such as the community leaders and people who can be trusted by the community, such as like people that look like the community and represent the community themselves. So if you're addressing the Latino community, making sure that like you have somebody that is Latino in your research group.
Excellent, thank you so much. Now we'd like someone from group three to answer how they would structure the partnership very briefly.
Hi, my name's Nikki DeVille. I'm from group 3, and we had discussed potentially implementing something in a rural setting. And so that would entail involving a community-based organization potentially. And so what we talk about was, as we're going through the grant process, to ensure equal partnership between a PI at a university, probably from a health-related department, such as a school of medicine or a school of public health, and also a co-PI from the community organization, whether that be like an executive director or program director or something from an organization that might help us implement our intervention. And then we also mentioned having a community advisory board made up of different members of the community.
Thank you, Nikki. Do we have someone from group 4 who will answer that same question too, how you would structure the partnership?
Yes, so we're kind of like the same as group 3. You know, we have some overlaps of ideas there, but we stress the importance of having an advisory group first, and that also takes care of the logistics and also the fiscal, you know, the finances, because we think that's really important. And we'll start with small, like almost like a listening session first, and then present it to a bigger group later on.
Thank you, thank you. For our last question, what strategies would you use to achieve effective group process? Do we have someone from group 5?
Yes, we were discussing doing a town hall kind of approach that would also include breaking out focus groups, which we thought would be a creative way to reach more targeted within the town hall meeting. We think that having the focus groups might help with mitigating concern over if people think they have enough credentials to participate. And we felt it was important also to have compensation to those participating to recognize their value.
Thank you, thank you. Do we have someone from Group 6 who wants to share some strategies?
Sure. We talked about the importance of transparency. We decided on to form the partnerships in the rural communities. So transparency, and we talked about consensus building and really having clearly defined roles and agendas, and perhaps establish formal partnerships could be effective group processes. Thank you.
Excellent. And do we have someone from our final group, number 7, that will share some strategies?
Yes. So we talked about the importance of building trust in the community and having community leaders involved, and specifically creating a community advisory board. And we discussed the value in following the community advisory board's lead in creating effective group processes that, well, I guess that's part of our process, but kind of following the community advisory board's lead when it comes to working with the communities.
Thank you, thank you. Thank you all so much. I hope that the experience was helpful as you're thinking about the approach that you would take to form a community-based participatory research partnership. And one thing I will lift up just again as one of the practices that we've found effective is if you want folks to be decision makers as a part of the process, that you consider forming a board or a steering committee rather than an advisory committee. So this is some food for thought and consideration. Next, I want to share a little bit about the partnership that we've been a part of, the Detroit Community Academic Urban Research Center, Detroit URC for short. That's so long. So the partnership has been around for 27 years. And I'll talk a little bit more about our goals in a moment, but the URC, as you can see, is a deep partnership. We've got 8 community-based organizations. We have the Henry Ford Health System and the Detroit Health Department, as well as the University of Michigan Schools of Public Health, Nursing, and Social Work. And all of these folks come together. They're represented on the URC board. And the URC is committed to applying its findings from research and interventions to interventions to help bring about policy change that help to enhance quality of life. Next slide. And so the URC was funded in 1995 by the CDC as one of 3 urban research centers in the United States. And they were part of an initiative called the Urban Health Initiative that was started by then CDC Director David Satcher. The other 2 URCs were in New York and Seattle. It'd be interesting to know if they're still around. And so we've got 4 goals, right? The first goal is to foster, enhance the capacity of and sustain community-based participatory research partnerships between academic institutions and Detroit-based organizations who are focused on promoting health equity. Our next goal is to enhance the capacity of academic, community, and health practice entities to conduct and promote community-based participatory research as a viable approach to promoting health equity. And I'm excited in a minute, we'll share a little bit what that looks like. Our third goal is to enhance the capacity of academic, community, and health practice entities to engage in policy advocacy processes. And then finally, our goal is to translate research findings to advance policy formulation, dissemination, and education at all levels of government and within organizations. And so the URC over its 27 years, we've had over 40 funded CBPR projects, 12 affiliated partnerships with over $50 million in funding from federal and foundation sources. We've had both academic and community partner institutions serving as a fiduciary. And some of the areas of focus or issue areas that we've addressed are food access, diabetes, heart disease, the built environment, asthma, air quality, and COVID-19. We've seen improved health status as a result of interventions such as reduced rates of asthma symptoms and high blood pressure. We've hired over 400 community members for full or part-time positions. I am a former community member who became an employee at one time. We've disseminated results through numerous publications, presentations, posters, and workshops. We've involved over 30 U of M faculty and nearly 400 grad students, including postdoc scholars. We've involved community-based partners as guest lecturers in classes, preceptors for student internships, mentors for postdoctoral scholars, and we continue to work to build capacity and translate research into policy change. So that is a bit about the work of the URC, and Barbara's going to share more about a specific one of our affiliated partnerships called Healthy Environment Partnership.
Thanks again, Sharita. So I'm going to try to go through this quickly. We do want to leave about 10-15 minutes at the very end for Q&A, but want to give you an example, as Sharita said, of one of our partnerships, Healthy Environments Partnership, or HEP for short. And I want to emphasize that this was what I'm sharing, what we're sharing was over, HEP was started in 2000. So this was over a 20-year period. And to acknowledge that, you know, for those of you just starting out, sort of not to be overwhelmed because it is pretty amazing what has been accomplished, but this is what you can do. And starting with this one-year grant opportunity, you can go off and do similar things. I encourage you to do so. So HEP is a CBPR partnership, understanding and promoting heart health in Detroit, and looking at the social and physical environment that contributes to racial and social economic inequities in cardiovascular disease. And the partner organizations are listed at the bottom. Again, community-based organizations, health and human service agencies, and the University of Michigan. We use a social ecological model, which I'm sure is familiar to all of you. What's important here is just, again, recognizing that individuals are embedded in these larger systems of families, friends, social and community networks, living and working conditions, broader social, economic, cultural conditions, all of which have an impact on health status. And that when we think about interventions, we try not to only think about individual behavior change, but what is it about these other levels that needs to change in order to impact health status? So HEP has been involved in a number of different projects and data collected. The initial was the social and physical environments and cardiovascular health inequities, which was predominantly a survey research study. This was the first study that the URC had approved that did not have an intervention component, but it was with there was enough trust at that point that there was a commitment to taking the data to use it to guide the development of interventions, and which is ultimately what we did in community approaches to cardiovascular health and Lean and Green in Motown. We conducted focus groups, surveys, we monitored air quality, we did a grocery store audit. You'll see some of the results of this in just a few minutes. And then we developed an intervention, a walking group intervention that we'll elaborate on as well. So just a few examples of the collaborative data collection processes that we use. We conducted focus groups that were co-facilitated with community and academic partners. We had a survey subcommittee with community partners to develop and pre-test the survey questionnaire. The steering committee finalized all major decisions about the survey, including questionnaire, data collection mechanisms, the sample. We had a youth photo voice project to understand youth perspective on neighborhood conditions and health. And the steering committee provided oversight for all aspects of data collection and analysis. And Shrita is now going to share some of the findings, and then we'll show you how we use the findings to guide interventions.
Thanks, Barbara. And I will try to go through this quickly, but some of these are some of these findings shouldn't be a surprise to you. So there's in communities with high percent poverty and high percent African Americans, we find there's an association with reduced access to supermarkets and reduced quality and range of produce. Also found that proximity to large grocery stores led to increased fruit and vegetable intake, as well as increased DGLO, or dark green, leafy, and orange fruit and vegetable intake. Conversely, proximity to convenience stores, we see a reduced fruit and vegetable intake, and there was finding of discrimination experience when shopping for food contingent on store type and location. And so here you can see what some of the focus group participants had to say about food environments in certain areas of Detroit. This particular grocery store I'm familiar with is located on the east side, and the building is still there and it is vacant. And so you can see some of the remarks from participants there. And we also noted that there tended to be less favorable environments in the east side and northwest Detroit as compared with those experienced by southwest Detroit residents. And so this graphic here, a doctoral student who conducted her dissertation with Healthy Environments Partnership made this map, and she was examining the distribution of grocery stores across 3 health study areas and in Southfield, which is a suburb right outside of Detroit. So right up in, what is that, the far left corner, that's outside of the sort of city limits of Detroit. And the map shows the different types of stores that are across these areas of the city. And so we just want to kind of call your attention to the finding that large chain grocery stores were more likely to be located in the suburban location or Southfield than they were in the city. And specifically, there were no large chain grocery stores on the east side of the city and in Southwest. And even now, I think we have a couple Audis, but you're not likely to find like a Meijer or, well, I don't know what the grocery stores are in your area, so I should probably not name. And then when we look at the retail food environment, so this map shows another aspect of the issue. So in some neighborhoods, there are a large number of convenience and liquor stores, and these stores tend to store or stock snacks that are very high in fat and sugar, salt, and calories, all the things that we need to not have. And you can see that there are a lot of these stores in the east side of Detroit as compared to, for example, the suburb of Southfield. And if I had a pointer, I would point that out, but hopefully you're getting the picture from the picture. And then also, there are long distances some Detroiters have to travel just to find fresh produce, but you'll see an overabundance of things such as McDonald's, for instance. Again, there's just not the access to quality, healthy food that you would find in grocery stores. And because of that, obesity is a really important risk factor for high blood pressure and heart disease. So unfortunately, because there's these long distances that folks have to travel, while conversely, they're in close proximity to things like this, this is some of the challenges that folks face. Then we also wanted to share a bit of finding from some physical activity environments. And so the first point here is basically that better sidewalk conditions will lead to people being more likely to be physically active. And similarly, when people feel safe, when there's presence of other pedestrians and absence of stray dogs, and traffic is more calm, that's also associated with more physical activity or greater pedestrian use of greenways. In this next example, we're presenting some data from photographs and interviews that really focused on aspects of the environment that might influence physical activity. And a number of community members spoke about the challenges that are associated with being physically active in Detroit. So in addition to few opportunities for outdoor recreation, there are also challenges associated with lack of equipment. There might be swings, but there's just chains there, not the actual bits that folks need to sit on to swing, and local recreation centers being closed. So a number of challenges, what makes it challenging to be physically active. And then here we see some of the challenges that are not as commonly discussed or perhaps as obvious that folks mentioned. So for folks from our immigrant communities, they talked about the challenge of related to surveillance by immigration and customs enforcement. Detroit is a border community with Canada, so we have an international border, so we have immigration and customs presence, and that has been a challenge in immigrant communities. There's concerns about dumping, often from people outside the neighborhood, right, that come and dump in neighborhoods and communities in Detroit, and there's inadequate enforcement of anti-dumping regulations. One person commented, I can't go out and walk without pushing my daughter's stroller into the street to get around piles of trash. And then finally, traffic on neighborhood streets, including in some neighborhoods, diesel traffic. One comment was there's so much traffic, cars driving up and down streets really fast, especially in the summer. To prevent that, we now have speed bumps on a lot of streets. I don't know that I'm necessarily in love with that idea as a solution, but these are some of the challenges that came out of some of the research findings. Next slide. Focus group participants gave a lot of ideas about ways to make neighborhoods more physical active friendly in order to create communities that would support an active lifestyle. And so that's some of the comments that you see here, as well as the pictures. Okay, Barbara, I'll turn it back to you.
Thank you, Sharita. All right, so we want to just, so our last bit on the case example here is, what did we do with all this data? Okay, we learned a lot from these different ways that we collected data, but we wanted to use it to promote change. And so we developed the Catch Path multi-level intervention, and which promoted walking, which I'll say more about in a minute, also promoted leadership, community leadership and sustainability through working with organizations to support the greenways that were going on in the city at the time being built, training and supported community health promoters and walking group leaders to start more walking groups. And we also promoted activity-friendly neighborhoods through a mini grant program, local policies for more activity-friendly environments. So back to that social ecological model, while the walking group was a major intervention, there were these other levels of intervening were also very important. So Walk Your Heart to Health was the name of the walking group intervention, which aimed to promote heart-healthy walking behaviors, to provide opportunities for other heart health activities like food demonstrations. Also, we had a heavy emphasis on social support for heart-healthy activities. And we used a lag study design. One of the things that's important about CBPR is that we feel that the traditional notion of a randomized controlled trial where one group doesn't get anything is not in keeping with CBPR principles. So the lag design meant that at baseline that we identified participants, we randomly assigned them to either the immediate intervention group or a lagged group. And then at baseline was collected on both groups, but then half of them, the intermediates, started walking immediately for an intensive 8-week program. And then at time 2, we collected data, both groups, but then second group started walking. So we were able to compare the results of the first group to when the second group wasn't getting the intervention. So that serves, so to speak, as a control group, if you will, but they got the intervention as well. Some of our, in terms of evaluation, we use pedometers to monitor steps, participant observation, attendance records, sessions, summary sheets, and our health indicators included blood pressure, lipid levels, glucose, body mass index, weight, circumference. We looked at behaviors and attitudes toward physical activity, perceived support. So all of those were some of the indicators to try to measure the impact of the walking groups on people's health. Some of the things we were able to find was that Walk Your Health WYHH participants, if you will, they walked more steps per day on days that came to the walking group. The walking groups met 3 days a week, but compared to days that they didn't walk with the group, but also after joining the group, walkers took on average more steps per day, even on days they didn't come to the walking group. And attending a greater number of sessions or a greater number of weeks was associated with greater increase in physical activity during the intervention and the maintenance period. So the intervention period was 8 weeks, but the maintenance period continued for another 24 weeks. And this presents the findings for blood pressure. We had, and what we found that on average for each increase in 4,000 steps walked per day during the 8-week intervention, there was a significant decrease in odds of having high blood pressure. We found similar results for total cholesterol, for blood glucose, for weight. And these reductions in cardiovascular risk indicators that were obtained during the more intensive 8-week intervention were largely maintained during the 24-week maintenance period. So even though this is just showing blood pressure, we had those similar findings for other outcomes. So we learned that it's low risk, didn't require a lot of training, appropriate for all ages. They promote peer support, leadership, group cohesion. Don't have a lot of time, but we spent a lot of time, our walking group facilitators who were community health workers put a lot of emphasis in the training on group cohesion and peer support. Here's a quote from one gentleman. I loved it. The people in the group, the community health promoters, we became family. Everybody in my household walks. I changed my diet, lost weight. Program should never end. In addition to the walking group, again, with our social ecological model, we also created a network of community organizations to support walking groups throughout the city to expand it beyond the 3 neighborhoods that were the focus of the study. We conducted what we called swag training, supporting walking groups to again train other community members throughout the city on how to run a walking group and what were the components that made it effective. We also did walking group capacity building through mini grants to support community change, that to promote activity-friendly environments and community building. So people were in the neighborhoods could apply for these mini grants to create things on the, activities on the greenways to encourage people to use the greenways. Variety of different things that happened through those mini grants. And we also did policy advocacy capacity building workshops to encourage people to how to bring about policy change, given what we had learned about all of the health, the stressors, if you will, that impacted our negative health for heart disease. So a lot of information thrown at you in terms of HEP. There's a lot of information I can lead people to if you're interested. We want to close before we open it up for questions is just briefly summarizing some of the benefits of using a CBPR approach. It enhances the relevance and use of data. It also enhances quality and validity of research. We have a number of examples of where we did engage our steering committee in trying to understand a given issue in a community and then use that understanding to develop a survey questionnaire that had a lot more relevance to the very community And so while we try to use where possible for survey research, for example, validated instruments, there were some stressors, for example, that didn't exist in any validated instruments, but they were very germane in Detroit. So again, tailoring it to the local community context enhance the relevance and the application of the data. And Sharita, just a few points, if you will.
Almost forgot to unmute. Yeah, so quickly, CBPR strengthens interventions, design, and implementation. You know, when there can be elements of distrust, right, of research in historically marginalized communities. And so, you know, for projects like the Community Action Against Asthma Project, we had a number of conversations with the steering committee. And, you know, there was this emphasis on the importance of being able to prove that the intervention was effective. And so we took steps in how we designed the intervention as well as in the implementation. So the recruitment and retention that was used in the project. The steering committee was instrumental in hiring community members as a recruitment coordinator and working with her to identify community groups. And so again, in the interest of time, I won't go into all the details there, but it was a very intentional process. And this approach definitely strengthened the intervention, design, and implementation. Another benefit of a CBPR approach is that the knowledge gained and the interventions taken benefit the community. So for example, not only are participants in the different interventions beneficiaries directly from the education and materials and skills that they obtain, but each of the projects is also committed to disseminating the findings and lessons learned to decision makers, so that helps in shaping policy decisions that help to enhance health and quality of life in neighborhoods far beyond the actual intervention, whether that's access to healthcare or food security, environmental quality. CBPR provides resources for communities that are involved. As we mentioned earlier, we've hired and trained community members as interviewers for a number of projects. CBPR joins partners with diverse expertise to address complex public health problems. So we talked about a number of those through the health initiative. We've done community action against asthma. That also is an example of that. CBPR increases trust and bridges cultural gaps between partners. So in Detroit, you know, there have been some historic challenge between African-American and Latino communities. That's one gap that we were able to bridge through a CBPR process. In addition, there were challenges in the relationship with the university and Detroit communities. Some of these things have been addressed through our CBPR partnership. And then a final benefit of using CBPR is that CBPR has the potential to translate research findings to guide the development of further interventions and policy change. So one of the things I just want to emphasize as we close out this part is that it's an approach that extends beyond an intervention or one research study, right? But in order to really apply the principles that we've talked about, and in order to apply the results, you know, we have to have a long-standing partnership and to be able to apply those results to developing other interventions and policies that will really impact and improve health quality in communities.
So thank you, Sharita. I'm going to just pass this slide, which is on lessons learned. You will have an opportunity to get the slides and look at that. It's more of a summary of all points we've already covered. At this point, we want to open it up to questions and discussion. So I'm going to stop sharing so that we can see each other again, which will be delightful. So please, you know, we have about at least 10 minutes or so. We really welcome comments, feedback, questions. And maybe the best thing to do is raise your hand or just start talking, because I may miss your hand since there's two screens here to try to monitor. Yes, please, Anne.
Thank you so much. It was a wonderful presentation to both of you. Thank you. One thing that we're looking at very closely in our community engagement core is evaluation. And we understand how to evaluate according to NIH and to provide those kinds of data. But how do you approach evaluation in community projects? We're thinking that that's got to be a CBPR practice as well.
So just a question. So, and obviously we didn't have a chance to get to it today. You know, what we did talk some about the evaluation of a given intervention. So for example, the walking groups, and talked about the variety of different ways we evaluated that intervention. In addition, with CBPR, one of the things that I think makes it unique and really important is evaluating the partnership itself and the partnership process. So I don't know if that's part of what your question is. If it is, you know, we've actually written quite a bit about that. Would be glad to share some of those references. We do it through a combination of, we have a survey instrument that we use that we invite partners on an annual basis to complete. And then we analyze that data, feed it back to the partnership. What's really important about the evaluation is that you use the data to improve the partnership. We also do in-depth interviews, and again, can share examples of the interview protocols that we use, where we interview every member of the steering committee and to try to get a sense, you know, to what extent are we following our CBPR principles? You know, we said, you know, those kinds of things. So certainly, I don't know if the partnership evaluation is part of what you're asking about.
Oh, I think that's great. Yes, and I'd love to see those references. That would be wonderful. Thank you.
Okay, probably the best thing to do, because I'm not good at putting things in the chat in half a second, is that we will send those to the organizers and ask them to send them out to everybody.
Thank you.
Okay, thank you. Yeah, thank you. Yes, please, Elizabeth.
Helps if I unmute. I'm wondering whether you've ever done any evaluation on, I guess I'd call it community cohesion, or even community happiness, because it seems like you'd have kind of a spread effect of benefits from what you've done.
So, I mean, there's literature out there on like community competence. And community competence would be the one I think comes the closest. And we did look at cohesion in the context of group cohesion for the walking groups. And so there's certainly literature there on how to assess group cohesion. Community happiness, I don't think we've explicitly developed any instruments that, but again, and I know, I'm looking at Mary Beth to make sure she's helping me with keeping notes, that we can share some of those references on both group cohesion and community competence that hopefully will touch on what you're asking about. Really important to track. Other questions? Comments? And again, let me look on the next page to see if any. Feel free to just jump in. You don't have to raise your hand. Okay, Jeff, please.
Yeah, actually, I'll jump on what I think Elizabeth was saying. It was Elizabeth, were you saying, you know, one of the things Sharita was saying is that either CBPR is for creating, there are communities within communities, and there are multiple communities. So the cohesion I heard Elizabeth saying was, can you get some of these multiple communities to be more cohesive, one next to the other, when they didn't used to be? So is what I heard Elizabeth saying.
Yes.
All right.
Right. So my question really was in terms of the makeup of the steering committees themselves. You know, have you ever had the situation where oftentimes, I guess in the literature, it's called volunteer sector elites, where it's the same old people being asked to be part of the CABs. You know, how do you keep it fresh? Communities are dynamic, they're changing. Leadership within communities are dynamic and changing. How do you make sure that the makeup of the steering committee always tries to reflect that dynamism in communities?
Great. So before I answer that, Sharita, do you want to say a little bit about the Latinx and African American communities coming together through this process, or?
Sure. Yeah, there was historically some distrust, right? Even though both communities experienced very similar challenges, there was a lot of distrust. And one of the things, the benefits of this partnership, focusing on different geographic areas of the city, is that it created this opportunity for relationships and trust building over time. And I think it's one reason why I try to just lift up that to be a real CBPR partnership, it can't revolve around one grant period or one initiative or intervention or project, because relationship and partnership that's equitable and built on those principles really does take time to establish.
Yeah. And I think maybe, thank you. I mean, we put a lot of effort on this, you know, on all the things we've been talking about today. And, you know, folks really hadn't worked together before from these two different communities. The Lower East Side is predominantly African-American, 97% African-American. Southwest Detroit is 70% Latinx. And, you know, I literally remember walking into meetings with, you know, someone from the East Side on the Southwest, and there's a gentleman that's, you know, my age, and he said, I haven't been here since I was a kid. And this is, we're talking about 15 minutes away, or maybe 20 minutes, right? I mean, it just never the twain shall meet. So just bringing people together and doing activities together. You know, one of our reach projects, you know, we were doing physical activity, and we were doing salsa dance classes in Southwest Detroit, and I can't remember the hustle classes in East Side. And when the two groups heard about it, they wanted to learn each other's dances. You know, you know, those seem like simple things, but they'd never happened before, you know. So, but it was, again, this really conscious effort of bringing people together and setting up, you know, dialogue and equity and respect. And we had some issues where people said things that were, you know, unintentional, but not, you know, but hurtful. And we talked about them. I mean, that got into the whole issue of conflict and dealing with issues of, you know, racism and unintentional bias and so forth. You know, back and to your question, Jeff, it's a great question. And, you know, one of the things that I don't think we emphasized enough, but in our partnerships, for the most part, not totally, the partners are organizations, not individuals. And the organizations are an emphasis on what community-based organizations that are embedded in, highly regarded by the community. They're not just service delivery agencies, if you will, which do good work, but may not be bilingual and bicultural if you're in Southwest Detroit, for example, and they're examples of those. And so first and foremost, they're very highly regarded, respected organizations. And then the second is, if an individual leaves the organization, then, you know, they retire, in a number of instances, that's been the case. It's not the individual, but the organization provides another person to sit on the steering committee or the board to represent that organization. So you get the wealth of knowledge and contacts and commitment that the organization, the credibility has in the community. And it doesn't have to be just one or two individuals. But it's definitely, you know, something we pay attention to. We've actually had quite a bit of turnover recently because of retirements. And then we've had to pay attention, and sometimes successfully, and sometimes we're actually working on this right now. How do you bring somebody on board to a group that's been around for 27 years and have them feel welcome and a part of it and embedded, and it takes work, and we're working on that, but we want to be sure that people feel like they have a voice, and they're really intricately involved, even if they don't have that same shared history. So I hope that touches on some of it. I think there was something in the chat. I'm not very good at monitoring the chat.
Yep.
And
it says what challenges associated with CBPR.
Do you want to speak to some of those, Sharita, and then I'll jump into?
Sure. So issues like cultural humility, right? How you enter a community is really, really important, and being able to understand and recognize privilege and difference, and still enter with humility and respect, right? And I think power dynamics it can be a challenge in CBPR partnerships. Transparency, all those principles and values, establishing norms, like it's really, really important work. A lot of times we want to get to the intervention or the research, but the partnership development and maintenance is really, really, really important.
And I'll just say a few more. I know we're almost out of time here. Thanks, Sharita. Those were great. Time is, in order to do all those things Sharita just talked about, it takes a lot of time, and that's a challenge for folks in faculty, faculty, and particularly junior faculty. I hear stories where people have said, don't do CBPR until you get promoted. That makes the hair go up on the back of my neck. Couple of things you can do. You can publish process papers. You can talk about your partnership development and publish those. There's lots of outlets for CBPR articles. The other is do other data analysis. You can do secondary data analysis of other studies while you're collecting your data for a CBPR partnership. But time is an issue, and not just for academic partners, community partners. Sharita has a major position at a major organization, and so how does she, justify the time on a CBPR project? Funding has gotten easier, I would say, but funding is always an issue to get funding, and the challenge of sharing resources equitably, and who's the fiduciary. We try so that it's not always the university, but community-based organizations can be the lead organization. That's a really important piece. And sharing power. For some people, giving up power is really hard. And that's a challenge. So I think we're right at time, and I want to be respectful. Again, I just want to remind folks or let folks know you will be getting an evaluation questionnaire, and really would appreciate the feedback. We really benefit from that. It'll be coming out as a Qualtrics survey. I don't know if it's today or Monday, but you'll get it sometime soon. We will follow up with the references and things that we promised. And I again want to thank the organizers for all your work in getting us here. And we're actually hoping to be part of this work for the foreseeable future in some future workshops with some of the grantees. So I wish everybody well in submitting your grant proposals. I hope all of you get funded. And I can't thank Sharita enough for doing this with me today, and Mary Beth, and again, just thank everybody.
And Sharita and Barbara, thank you so much for the wonderful presentation today. I think we all learned a lot, and I wish everybody a happy Friday afternoon. So thanks, everybody.
Thanks so much.
Everybody. Thanks, folks. Take care. Stay well.
Bye-bye.